Welcome everyone to today's program. I am Robert Kurtz, editor of Becker's ASC Review and moderator for today's program. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have. We'll follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You'll also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. First, we have Todd Logan, Regional Vice President of Sales for SourceMedical Surgery Division. Todd has more than 10 years of experience with surgery information system solutions. Throughout his career, he has held numerous roles, including implementation, product development, and sales. He has delivered CEU presentations on such topics as maximizing profitability and improving inventory management in a surgical environment. Prior to his current position, he worked for a Fortune 100 company in healthcare information systems. He also founded his own software services company and acted as CEO for 4 years until the company was sold. Todd has an MBA from Regis University in Denver with an emphasis in healthcare management. Next, we have Bill Hazen, the administrator of the Surgery Center at Pelham. Prior to this position, he was employed by Spartanburg Regional Healthcare System for more than 25 years. Bill began his career as a staff nurse in 1985, became a certified hyperbaric technologist in 1991, and was promoted to coordinator of hyperbaric medicine, where he eventually became the manager. From 1999 through 2005, he served as Director of Marketing and Development, as well as the Director of the Regional Wound Healing Center, the Interstomal Therapy Department, the Sleep Disorder Center, and the EEG Lab. In 2000, he was promoted to Director of Special Projects while building the Surgery Center at Pelham. It is now my pleasure to turn the floor over to Todd to begin today's presentation. Todd?
All right. Hi, everybody. Thank you for taking the time to join us this afternoon. Again, my name is Todd Logan, and I'm thrilled to be co-presenting along with Bill Hazen, who is one of our clients and also one of the true thought leaders in our industry. His center, I would say, exemplifies what we call best practice process of maximizing the use of technology to help improve his bottom line. And now my goal of this presentation is just to provide a backdrop for the discussion and let Bill explain how this process has worked for his center and how it can work for yours too. Slide, please. So when we talk about electronic health records or EHR, there are myriad benefits, some clinical, some financial. Now, when we look across each of these particular items, they could each fill probably a full hour of discussion. But because of the time constraints, today's topic is going to be focused exclusively on really the cost benefits delivered from the point of care documentation. Next. All right. So I'm certain many of you have had similar discussions as this cartoon depicts, where you feel a disconnect between what your goals are as the administrator of a center compared to maybe what the practices of the physicians may be. Although it might appear to be somewhat entertaining, discussions like this can be sometimes challenging, but they're necessary to have, because if you can't get your physicians on board, there's no way that you can really have the sustainable changes if they're not participating fully. Slide, please. So one of my favorite quotes regarding case costing and working and maximizing profitability from point-of-care charting came from a consultant I worked with in the past. And what I try to do is I try to make this point, drop off the article for which this quote came from, to all the clients who aren't currently using the detailed case costing, because they truly are leaving money on the table, whether it's in the form of lower reimbursements, higher supply costs, higher administrative costs, or a combination of all three. Like I said, they are losing money, and they need to try and have some sort of strategy to address that. Slide. So in my position, I've had the experience and the opportunity to literally visit with hundreds of surgery centers across the country. And because of the recent downturn in the economy, and everybody's experiencing either lower reimbursement, lower case volumes, other factors that are affecting their bottom line profitability, the landscape of the industry is really kind of shaken out and left maybe about 1/3 of the centers operating today in the red, operating in the red, a third that are break even, and a third of them are still being financially successful. And what we're trying to do is educate folks to say, if you can use detailed case costing reports to carve out an average of, let's say, $50 per case, that could move centers from one category to the next, meaning if you're operating in the red today, if you can create that extra $200,000, $300,000 to your bottom line, now you're operating at a break-even basis. Or break-even, now moving to the sector where you're going to be financially successful. Next. So easily said, but where to start? So the process that we're focused on today involves really the clinician-physician charting, where they're charting on a piece of paper in the OR, then handing that information to somebody clerical, where that information is then entered into the information system. The problem with that process is really twofold. Number one, it's redundant, and you're creating extra work for folks. And number two, more importantly, this process is fraught with potential for errors that can lead to a drastic distortion of what was actually used during that case and create unusable reports. So then, once these reports become unusable, unreliable, then folks just go ahead and scrap that whole concept altogether, and then they go back to doing what they'd done before, is either not doing case costing at all or just taking an average, which can be very inaccurate. So next. So here's what we're trying to get to. What we want to do as far as best practice is actually capture that data at the point of care with your EMR, EHR system. It'll be a lot more efficient, so you remove that one step of having that data go to somebody clerical to enter in. And it also ensures that there's accurate documentation of what it was actually used. So now you can produce very accurate, very reliable case costing reports that you can help or start to make strategic decisions for your center on. Next. Now let's talk about that. So when we look at an actual report, here's a report that can be generated from the system. So you're looking at what you're producing from top-line revenue, what you're getting from the reimbursement from that procedure. And then you can compare that to fixed costs allocated across all your procedures, your staffing based on who participated in that case and a portion of their annual salary, all disposable supplies, all the way down to equipment depreciation. So you're coming up with a true total cost of that case, and then the true profit or loss in some cases of that case. Next. All right, so I provided you the theory, but how does this really work in the real world? So like I said, what I wanted to do is step aside and provide the backdrop for the discussion and really turn this over to Bill and have him explain how he was able to get his surgery center to really take advantage of this technology and help drive savings to his bottom line. So with that, I introduce to you Bill Hazen.
Thanks, Todd. I appreciate that very much. Welcome, everybody. Next, please. Like we said, we're going to talk a lot about this report. If you're not familiar, this is a report out of Vision. And the detail that we go to that we'll talk about even a little more on how well you can see it on the slide is we actually cost here all the way down to crayons and how much they cost. So we'll talk a little bit how we've taken that and used it with the employees. So next. You know, a little background is buy-in is sort of where we had to start all this. We started our center out live with Vision when it first came out. We were one of the first customers with the Vision with Scott Palmer. And we really wanted to push it to its limits, which we succeeded in doing. To get your employees to really do this, we have created a complete atmosphere of the employees truly believe that this place is the best place to work. I mean, you ask them. We have visitors here quite a bit, and they brag on the street. They brag while they're working, and they have a good time in doing it. And because of that, we've been able to have a 100% patient satisfaction for 3 years running now, and we truly commend that to our employees of how they do things. And some of the ways that we've done it is employee-driven decisions. We try very hard here to let all the employees weigh in on everything we do. It's not a monopoly from the top. We actually changed scrubs to try to reduce prices. We put 4 employees together, looked at different scrub companies. They went with the cheapest. Health insurance was a big battle I'm sure all of you are dealing with right now in your fixed costs. We're getting reimbursed less, but yet our health insurance is going up every year. So again, we put about 5 employees together on this,
gave them 6 different plans, and our employees actually opted to go to an HSA account where they had a $5,200 deductible, $5,200 deductible, and the company actually contributed some of that to that. So getting that culture to get your employee to really have ownership is crucial in where I'm going to go through this presentation. And again, with that being said, you know, the whole philosophy here, and my philosophy as a manager, is to literally work myself out of a job. The less decisions I have to make for the employees, the better the system is going to run. We have a lot of very mature employees that have been given a lot of responsibilities. You all well know in ASCs, if you came from a hospital, you had a risk manager, you had all kind of things, departments you could rely on. And of course, in the surgery center, you know, we all wear 100 different hats. You know, I was a trauma nurse for a long time when I first started, so I actually turn rooms over. I empty the trash and I mop the floors in between rooms because they don't allow me to do much more than that back there because it concerns them that I'm a trauma nurse. So it works out pretty good, but seeing the administrator back in the ORs I think is crucial. Our entire philosophy at the center is based on one thing, and it's loyalty, and it's a two-way street. All of our employees during their orientation, we discuss loyalty with them and how they need to be extremely loyal to the center, and we take that to the point of our code of conduct. If you're not loyal to the center, it's not the place for you to work, and other employees will tell you that, and we work very hard, and for that, you know, they get my loyalty 100% is I protect them against the physicians because physicians aren't allowed to misbehave here, and they act differently than they do in a hospital. The next part, my sandbox, is kind of funny because we kind of talk about you know, I make the financial decisions for my doctors, and I've built a tremendous rapport with them. I had a GI doc come in my office one day and tell me that, you know, he wanted to tell me what I should do with the family while he was doing the colonoscopy. So before we even started the conversation, I said, well, you know, we need to make a decision. Am I going to do the colonoscopies and you run the business, or am I going to run the business and you do the colonoscopies? And needless to say, he left my office pretty quick, and we never had to have the discussion. But the biggest thing that I can tell you is everybody talks about your administrator or a CEO of a business. You may want to call yourself that, but you're not. What you are is you're doing adult daycare. Because as you've all known, when you're working with a whole bunch of physicians, they kind of have their own ideas. So you just got to kind of root them in the right direction and keep them going. So that's how we sort of refer to the job at the top here. So next, please. So let's talk a little bit about costs. Like we said, we've put in our fixed costs, which are important, and there's 2 different ways you can do this. You can do this by the minute, which your physicians would prefer, especially your GI physicians and your eye doctors, because their cases are so quick and it costs them less to the fixed cost. The problem is, unless you're lucky enough, which we aren't, to be 100% utilization, you'll never cover your fixed costs. So we mark ours out and we do them off our budgeted cases for the year, so it makes a rather high fixed cost. But you got to cover that somewhere during the year. Staffing, of course, we keep our salaries up to date, so it's accurate to exact amount of time, and with vision it's very easy to track how long they're in each area. You can actually watch them going through the system, so even as an administrator in your office, you can look at that. It's very helpful, and you can intercede if patients are having to wait because the physician's behind or whatever, again, which helping with your patient satisfaction. Again, what I'd like to talk about is how the detail that we've really taken this down, and this all comes to building the system when you put it in. You must start from this from the beginning. You cannot go into this halfway. You have to build your preference cards exactly, and your staff has to be responsible for updating them on a weekly basis. If your costs are not accurate, your output information is not going to be accurate. So like I said, we've taken it all the way down to crayons. And crayons are 9 cents. As you can see in a coloring book, is 60 cents. We actually asked the kids if they're going to color. If they're not, we're not going to give them a book. It's 69 cents. We actually count the 2x2s in post-op that we use to DC the IV. We've actually taken the Coban that we wrap them with and figured out how much it costs to use 8 inches of Coban to wrap the patient's hand with. So, I mean, literally, we are taking it to the penny. And again, we'll talk a little bit more about why this is so important. Next, please. Live costing. This is exactly what you have to do. We are right now implementing the EHR at the surgery center, but we were actually using Vision almost as an EHR beforehand. We have desktops in every OR or laptops, and our employees are required to charge everything that was used, including implants and everything. The only cases that we do not require that on is our cataracts because they're too fast and they can't cost that fast. So by doing that, we literally know when the patient puts his foot in the car when he leaves, we know exactly how long he was in the center in each area and exactly how much the case costs. And we've used it in a lot of ways, and I'm pretty in my doctor's face a lot. So if they're using a lot of implants in an orthopedic case, I'm seeing it. And my nurses are calling me and telling me. And I've been known to meet a doctor at the door coming out of the OR and show him the printout that I just, the previous slide, and say, we lost $150 or $400 in this case. You need to walk out the post-op and ask all your partners for $100 because that's what you just did. And what it does, it helps you do is to teach pricing. You know, everybody knows the price of gas because they drive by 10 gas stations every day. We all know the price of food because at the grocery store they put the price up. I've never understood from my 20-plus years in a large institution why we didn't push costs down to the nurses that were using it. By making your employees actually enter these costs as they do them, they know exactly how much everything costs. So they learn that if there's 2 sutures that the doctor normally uses, that they may come up and say, hey, doc, you know, we can use this one at $7 a piece, or we can use these other sutures that are much, much cheaper, much more expensive either way. And the doctors are very minimal to that because they really don't understand what things cost. They see the rep in their office and they tell them it's the latest and greatest push lock implant to use in a shoulder case. And they have no idea that it's $425 or $385, and the one they were using a week previously was $250. So by actually taking these, we actually post them in the units, and we actually post in our break room with secret numbers, which it doesn't take the physicians long to figure out who they are, of like ACLs and who has the cheapest. And what that does is one orthopedic surgeon will go to another and start talking to them. How do you do that case cheaper? And it actually has become a very positive thing. We try very, very hard to put a little bit of competition between them because at the end of the day, in our case here, we're 50% owned by physicians and 50% owned by a hospital. And, you know, as we all know, money, you know, drives the world. To kind of show you where we've gotten this, where we've taken this level, the physicians, I have 5 physicians that were all either on my med exec or my board. And this is probably one of my greatest stories. She's now a clinical director for me. Her name is Kathy, and she was working in pre-op as a pre-op nurse. And they were all complaining about the coffee because I'm not going to spend any more money than I have to spend. So I told them, fine, bring in 5 vendors and see what we should do for coffee. So they did. They brought in the 5 vendors for coffee. I never paid any attention to them at all. And so it came back, and they told me what they wanted to do. And one of our chairman of the board came in on a Friday to do a case. He's a podiatrist, and Kathy met him coming out of the OR, and he said, and she told him, she goes, Dr. Bensel, they brought in this new Keurig machine. I'm sure you're familiar with them, the little 1 coffee cup things that are great. She said, we've got one back there, and it's fantastic. She said, you're more than welcome to have a cup. She said, but don't get used to it because it's 62 cents a cup, and right now we're paying $5. He proceeded to walk out of post-op straight to my office, shut my door, and say, I think you've succeeded in how you've got the employees to buy in and know what it is about cost. So next, please. So how do you do that with your employees? Everybody always asks me, how in the world do you get your nurses to chart live in the OR? Well, first of all, I don't mean to be mean when I say this, but they work for the center, so it's, you know, that's part of their job requirement, and we actually track it, and they're disciplined if they don't. But the easiest way we found to do it, we institute this right off the bat, and if you're not under this program, I would highly recommend you talk to your doctors, is we implemented a bonus structure. The bonus structure, what it does is 5% of all profits that are paid out are split equally among all the employees. It doesn't matter how much they make. Everybody gets exactly the same piece of pie. They have to meet 5 goals, one of which is patient satisfaction, physician satisfaction, case costs, case revenue, and inventory. So that each person here is in charge of a certain part of the inventory. So again, you're keeping your costs down by that. They know what things cost because, again, they're looking in vision. So every time they go to open something, they know for every dollar they save, they are truly making 5 cents into their pocket. And it's made a tremendous difference on how they look at things. They know if our caseload's down, They don't expect the bonus. But it's a substantial amount of money to them. You give an employee $1 an hour raise, and in 3 months ask them where it is, they can't tell you. But if you keep your bonus structure done on a quarterly basis, you can keep people or employees focused for 90 days. It's too hard to keep them focused for a year. Like I said, they forget about the raise. But my employees, you can come out here and talk to them, and they can tell you what they spent every one of those bonus checks on. So it's a way to keep them focused and to use it accurately. By doing all this and keeping it accurate in your system, everybody, as an administrator, one of our biggest hassles is budget, especially if you've got a hospital partner and they're all CFOs and CFOs, they really like to talk about the budget. As administrators, we don't really, especially if we're nurses, we're more task-oriented. We want to talk about what we're doing in the OR that day and how we budget every day and adjust our schedules every day. From a hospital standpoint, or physicians, they don't understand that. So by keeping it very accurate, you can literally download and envision your cost across the board for every single physician or specialty. By doing that, you can load your cost into your spreadsheet for your budget. And typically, my budget every year takes me approximately 1 hour to do. And that's not an exaggeration. That's exactly what it takes for me to do. In the same respect, one of the things we've been able to do is use it for vendor negotiations. I know that all of you have met with vendors and you talk about what the price has got to be lowered to for the implant or whatever, and of course they go back to their boss, and their boss says, well, they're just trying to make more money, you need to go back and beat them up, and it can very easily become a tenuous situation where it's stressful that you don't want to do. And we have a tremendous control over our vendors. My physicians are not allowed to bring anything into the center. If they schedule a case with something in the center that hasn't been approved by administration, and we don't find out until the day of the case is canceled. And we started that, and we lived to it. So what you do is you take that same report that we showed you earlier, and you plug in. You can easily go in a preference card and change the implant cost that the new orthopedic implant is. And you can run that report. You can hand that report, take the name off, hand the report, put it in an Excel spreadsheet, hand the report to the vendor, and he can actually take it back to his boss and say, this is what they're getting paid on the case, this is what they make. And then, you can see how you both got to make money, which is where it's got to be. So it's made those situations a lot easier to deal with. In the same respect, we've taken it to the next level of payer negotiations. Payers always want to know what you're charging because they don't trust hospitals because they overcharge. When I first opened this center up, we have 2 centers. We have a sister center at 7 beds, ours, and 2 GIs. We have 4 ORs and 2 GI rooms. Blue Cross Blue Shield is one of our biggest payers. And implants were killing us, especially on orthopedics. So I went to Blue Cross Blue Shield, and I met with them, and I said, I want you to pay for implants. I don't think I've been laughed at that hard in I don't know how long, because they said, no way, we know what you charge for implants. You guys all mark them up 300 or 400%, which is what hospitals do. So what we did is we said, no, we're actually going to show you our costs of what it costs us to do the case. We're going to show you what the implant costs, and we're willing to send you an invoice for every case with the bill for what the implant costs with no markup whatsoever. Blue Cross Blue Shield allowed us to try that for a year, and I'm pretty sure that everybody in our state now is getting the same deal. So we didn't have to raise the grouper rates and argue so much about groupers. We've managed here at our center by keeping our costs so low that we have not had to raise our costs at all for 6 years. My board is always pushing me to raise costs, but I think there's a happy medium to how much money you make and how much you need to make. And I think it looks good. And we actually publicize in the paper every year and talk about how we have not raised our costs, which I think is substantial in healthcare. And I think right now what you're finding is more and more of your patients are much more in tune to that and paying attention. They're actually having, we're actually having a lot of patients call and ask us, start price shopping for us. And we can actually get in detailed discussion with them and tell them if they think it's too expensive, we'll be willing to share with them. We do the same thing with our employees. We talk about every month, we share a tremendous amount of financials with them. The employees, every month, they're told what the financials of the center are, down to every detail. Again, this goes back to the loyalty thing you do. If you've got them on board, you can share this information, and it's no longer a place to go to work in the morning. It's actually, they actually feel like they have ownership because it's like they have a share in the business. Last year, we, in this state, we had a tremendous, well, it was actually over a 4-year period, the workman's comp changed our reimbursement drastically from 87% of bill charges and 120% of implants to 140% of Medicare and no implants. We fought them for 4 years in court, and eventually we won all the way to Supreme Court and then lost. And what it meant to our center alone, we do around 500 to 600 cases a year. It was a $2.1 million net decrease for us. So it was a huge hit to the center. I think the take home of this entire thing is that we were able to withstand that because we have done such a tremendous job in keeping our costs so low and knowing what they are. And like I said, teaching our physicians and changing practice patterns a little bit. You know, you always want to do the best thing for the patient, but it doesn't mean that you need to use the latest and greatest suture because it may not be any different than yours. It's always a physician decision on what he'll use on the patient, but if they're better educated, they can make better decisions. The bottom line is, you guys are seeing it, we're seeing it, like I said, our payers are paying less and less. Medicare, we're bound to take cuts in Medicare over the next year and Medicaid. Our state has already said that after the last week in April, they're not going to pay for Medicaid cases until in July when their fiscal year begins. They want to give us vouchers. So if you haven't went to a system like this and you aren't case costing, you're going to have to. It's going to be the only way you're going to survive. And it's just so easy to do it when you can get your employees to do most of it, and it's right in front of you. When I first came here, I needed this gauge to let me know that I was making money every night. And again, the same thing. I didn't know a lot about, I built 2 surgery centers, but I didn't know a lot about how they actually operated. So by looking in vision and seeing these costs every day, I can very quickly understand what cases cost me. So I could say, if I do this many orthopedic cases a month, if I do this many ENT, this is how much money I'm going to make by the end of the month. We run a perpetual inventory, so I know what my inventory is every day. And again, that's just money wasted on the shelf. The bottom line, you know, it's simple, it's easy, and your nurses will and your physicians will appreciate you doing it because it's easier to sit down and understand them, what you're doing. Like I said, I have no problem with my physicians at all. They follow right along. They don't make business decisions. They rely on me to make those because we've been very good at keeping the costs. And I think we average a little over between $235 and about $248 in cost for our across the board, and we're multi-specialty. We do all specialties. So that's pretty low in how we've been able to do it. And, you know, with that, you're tracking, like I said, you can track all the way down to exactly how long your patient's here. We average a colonoscopy is in and out the door in about an hour and 48 minutes. That includes the time they sign at the front till they put their foot back in the car. You're tracking your drugs you're using by anesthesia. Most of you places, I'm sure, don't employ your CRNAs, so that's sort of a hard thing to deal with. But what we've done there is we've aligned their bonuses with the anesthesiologists we contract with to be in line with the bonus structure we have here, so we're all on the same page. I know that was kind of quick because I talk kind of fast, but I hope that's a fairly good run over of what we have and what we do here. And if there's any way we can help you, let us know, and I appreciate your time. And this time I'll turn it back over to Rob.
Thanks, Bill, and let me certainly thank Todd as well for the introduction to the program. This now begins the Q&A portion of the program. I want to remind our attendees how they can submit questions. You do so by typing them into your control panel in the space labeled Enter a Question for Staff and click Send. And we'll try and get to as many of those as we can. We already have a few coming in, so why don't we just jump right into it. First one. I believe this is directed towards both of you. How do we get, how would this attendee wants to know, how do they get their physicians to agree to spend money on an EHR to achieve the benefits, Bill, that you described?
Well, hey, Bill, let me take the theoretical aspect, then I'll let you describe how it actually works. Now, from our standpoint, from vendor standpoint, we do have some very detailed analytics to walk through, do an analysis of your organization based on what you're doing today, what you're spending your money on today from your manual processes, and come up with a true return on investment analysis. Now you can take that ROI analysis and then you can review it, you can add to it, discount things that we might have missed, but that's going to come or arrive at a fairly accurate figure that you can utilize at least for your budgeting purposes. So that's how it works in theory. So Bill, why don't you tell them how it really works once they get that report?
Yeah, I mean, it's an initial cost up front, but I think Todd made a good point. If you, again, if you're tracking everything in Vision, you really know what you're paying, and I think you'd really be surprised when you start looking at how much you're spending on printing to have your forms made, how much you're spending for the folders to put them in. This is not exaggeration. We've got it down to a science. Our turnover times are 8 to 10 minutes, and they don't get much past that. No matter what, and we've actually made our charts when they were paper very easy for physicians to deal with, staff to deal with, so it was quicker. So that was a higher expense. So what we're finding by going to the EMR is that we're actually going to save money. Like I said, we went live Monday on the EHR, and we told our physicians we didn't expect them to do anything in the EHR for 2 weeks. Today, we had 3 physicians come to us and say, can I just go ahead and do it in the EHR today? I'd rather. Most all of your doctors, at least what I'm experiencing, is they have got EHRs in their office. It's also presenting a problem that if you haven't been through your Medicare survey yet, your 3-day Medicare survey, you're in for a tremendous surprise. It's totally different than anything I've ever been through. I went through Joint Commission at the hospital. And I was in charge of all clinical areas other than nursing in the hospital. We employed 6,000 employees, and it was nowhere near as bad as 3 days with Medicare in a small surgery center. And one of the things they're really focused on is your history and physical. And what you're going to find is to get truly compliant, to be within 30 days, or at least our state is within 30, and Medicare is within 30 days, and it has to be updated day of, is with the new electronic medical records, they're seeing patients out further than 30 days. So they're trying to handwrite stuff in, and that doesn't fly. So they're going to end up doing a lot more history and physicals day of. If the information is all in that EHR, it makes it a 5-minute process for them to do a day of, and it makes it a whole lot simpler. So I think what you're going to be able to do with your physicians is focus on the money, but you're also going to tell them how it's going to benefit and make their life faster, because most of my physicians will tell you they truly do like the money that they get as a distribution, but the biggest thing they like about the surgery center is that they get their surgeries done at half the time that they would at a hospital, and they have a higher quality life at home. And I think that you can take that home with the HR too, about their quality of life, and they'll overlook the money a little bit.
Excellent. Thank you. Let's move right into the next question. Is there a requirement date for ASCs to have EHR?
Yeah, that's a great question. We hear that all the time. We just went through the process because we not only work in surgery centers but also surgical hospitals. We just got our meaningful use certification for our hospital module a few weeks back. So we've seen that obviously from the inpatient side as far as the regulatory requirements and moving to electronic health records and all the requirements that go along with that. And we're anticipating this to come along in the ASC industry as well. Now, although we don't have a specific date from a federal level, we're actually seeing some pockets across the country. Minnesota is one state that I can think of as an example that's actually requiring all electronic documentation, including from ASCs, by 2015. So we're starting to see some of these local requirements starting probably which is going to start pushing the federal requirements and getting surgery centers added to what's now required for the inpatient setting as well as the physician clinic setting.
Yeah, I think what you're going to see too the big push for AHRs were that they want you tracking your medication. When you give a medication, they want it electronically checked against the patient. That's been a little challenge with us because CRNAs are hard to change what they do, but we've made them use a medication page. So I think it's going to come, like Todd said, it's going to come faster than you think, for the simple reason that they want you to be checking allergies and things in medications against the patient. So.
And one thing, too, that we're seeing, I guess what we can learn from the physician side and the hospital side, is it is creating significant backlogs of people who are, again, sitting on the sidelines and saying, oh, we'll wait until we're pushed to do that. Now that there are better requirements, now when the people are trying to jump into it and get implemented, they're finding that it's taking longer than they had wanted to, just because a lot of the companies that provide these services now have become so backlogged because there's a glut of people that are demanding to get this done as soon as possible.
Yeah, Todd, a side note of that too, I would say that, you know, if you look at what we talked about today in costing and using it live in Vision, you know, we did that from day one, and we've been pushing Scott to have an EHR, because if you're using just Vision without the EHR live, it's almost an EHR already. I got to tell you, the transition here has been, I've done a couple of EHRs. I've been Centricity and Logician through the hospital systems, and it was a big ordeal to change over. We're finding that this is very close to what you have on paper, and the transition is very easy. We literally we've been working on this for a good while with Source to make a lot of changes, but when we actually started training and going live was probably less than 30 days. And we're doing almost, we said we were going to do one room a day, and we're our third day in, and we're doing all of our rooms already now. And we're actually doing it on paper and in EHR. So it's if you've got that system in place, the EHR transition is so simple.
Excellent. Thank you both. Let's move into the next question. This attendee says that their physicians are resistant to change their preferred products. Bill, I think, can you speak to what some of your tricks would be to do so?
Well, again, I just show it to them in writing. You know, I make the report, and, you know, I go back and show them and say, you know, you want to use this product. This is what we're going to lose doing this case. You know, now, granted, you know, that with the audience, I'm not sure exactly how many of you are physician-owned, hospital-owned situations. My world is a lot easier because I have physician ownership, and they pay a lot more attention to what they're willing to do. But again, physicians are not, normally, I should say it across the board, are not great businessmen. They're just like nurses. They weren't trained. You don't take business classes, which I think is a huge mistake. So, you know, when you can start teaching them about it, and they are becoming more interested because they are using EHRs in their office, and they're starting to see their costs go down. So what we're hoping is they're taking some of this, and we've actually had physicians come to us and say, I'm taking this back to my office and look at what I'm paying for a 4x4. How many are we opening? So I really think education is the hardest thing, and then also the peer pressure. If you're having trouble getting through one of your physicians, let one of your other physicians go through it with them. Have him pull them aside in the hall and say, look, you know, I was looking at the cost. I'm pretty sure this is yours. You know what? Can't we talk about what you're doing, and maybe we can do it quicker, or we can do it easier? And, you know, then you play that funny line of, well, if I used a better implant, I do the case faster. Well, are you using 100% of your block time? If you're not, that's not a real warranted argument. So I think you use the information out of Vision or out of your cost accounting. Cost accounting is huge, because then you can show them and educate them, and use your other physicians as their peers to influence.
Excellent. Thank you. Moving into the next question. And I think you might have touched on this a little bit, but how long would you say it takes to implement such a system to be able to get the data?
The load up is difficult, and like I said, you have to do it immediately. You can't say we're going to start doing things. We actually started the upload probably 3 months before we opened the center, started loading in all our data. But there's a lot of great ways. Most of you are probably with a distributor, I would assume. Some people have chose not to do that to save money, but the money you're paying with your distributor, you can negotiate that down. It's probably worthwhile because they can electronically implement it into your system. Source also offers some products that will actually, when you check the product in, it will generate, it'll take the PO and send it to QuickBooks and generate it over so you can use it. So you get your preference cards built and your inventory built up front, and then it's not much upkeep afterwards. But I would say from our experience, and Todd, you can probably talk about this a little bit more, but it took us about 3 months to get everything in Vision originally. And remember, that was 6 years ago, and I'm sure that the uploading system has gotten a lot better. So Todd, you can probably talk about that.
Yeah. That's fairly accurate as far as that time frame, about 3 months. Now, there's two different scenarios. We have folks that are using the core system and then going to EHR, and that's one time frame. Then there's folks who are starting from scratch or coming over from a different system, and we have to build everything all together. So we say, again, 12 weeks for a normal implementation, and for everything included, all of the point-of-care charting, all of the electronic health records, probably a little bit longer than that. And part of that really is dependent upon the resources at the facility. Are there going to be different resources that can be applied to doing the EHR that are doing some of the inventory loads? Are those going to be the same folks? That you have to keep in mind that, especially if your center is open already, that you have your current tasks and your current cases, current patients that you have to tend to. So this becomes just an added job on top of that. So we want to make sure that it's a comfortable time frame, number one, and number two, that we're not putting undue stress on the staff. So when they do go live on it, that they're going to be able to use it properly and that everything's done correctly. Because it is tough to go back. I think Bill has made that point. If you do it correctly, take your time to build it right the first time, you're going to reap the benefits of it for years to come. But if you don't do it correctly, then you're going to have some challenges as time goes on to really get the data out of it that you're hoping to get.
Yeah, and like Todd said, if you don't, and I'd even push that a level further, if you don't do it before you go live with it, you won't do it. And you're going to fight with it forever, and then you're going to try later, and it's going to be very frustrating, and you're just not using the system. And as you know, I'll politely tell you that Vision's best attribute is just costing. I mean, it's just amazing. It makes it so simple. So I mean, I can't imagine why you go out and get a program and then not use it to its fullest capability. I mean, like I said earlier, it's with the stresses and the income on us right now, it's imperative that we look at every penny.
Excellent. That's all the time we have for the Q&A. I'm going to give our presenters a chance to share some final thoughts in a moment, but those of you who submitted questions we did not get to, we're going to make sure that those questions get to our panel today. And also, you should feel free to respond to any of the emails you have already received or will receive concerning this program and share any additional questions or feedback you have through those. And also, both of our speakers have been kind enough to provide their email address as well as their phone number in this final slide on the screen. Certainly encourage you to contact them directly if you do have any questions or you want to learn more about what was covered today. With that, Bill, Todd, want to give you a chance to have any final thoughts before I conclude today's program?
Yeah, thank you. I have one closing thought, and I'm sure Bill has a couple too. But first of all, we thank you again for joining. I hope this was helpful. As I said earlier when I kicked it off, there are myriad benefits to using an EHR. This session was just focused on those costing benefits. Hopefully you're able to find those useful and be able to utilize those benefits and help bolster your case for implementing such a system. But I did want to say we are planning future presentations as well where we're going to be focusing on some of the other benefits, such as the clinical benefits of the EHR as well. So I did want to throw that out to the group.
Okay.
Excellent. Thank you, Todd. Bill, do you have some thoughts?
Yeah, the only thing I'd like to add is, you know, like we talked about, using this information to your advantage. I mean, you can push your physicians for better practice and lower your costs at the same time. You're pushing your employees to have ownership and to understand it. And, you know, what we really haven't even talked about, and Todd would probably chuckle about this, is you can push your software company. The harder you use this information and the deeper you dig, the more you push to make them make a better product for you to use every day. Because at the end of the day, if it doesn't work out here in the real world, it really doesn't matter what's sitting up there in the IT department. And believe it or not, they sometimes don't understand what we do as we don't understand what they do. And by dealing into this and really using the product to its potential, I think there's been a lot of changes in Vision, and it's really pushed it to be a better product for everybody. So, you know, you're as responsible as the administrator out here to make your other resource on the side work as hard as you do so. So I hope this was helpful, and if there's anything I can do, please don't hesitate to email me.
Excellent. And again, thank you both, and I want to thank the attendees for joining us, and I hope that they'll certainly join us for future presentations, including the ones that Todd discussed. With that, this concludes today's presentation. Thanks again, Bill and Todd. Thanks to the attendees, and I wish you all a terrific afternoon. Thank you.